Good afternoon, everyone. I want to talk briefly about trauma and stress-related disorders. Um, our discussion from this week's class, and I want to make sure we do some clarification. So, before we begin, I want to reflect on this. What is trauma and what counts as trauma? The answer isn't as simple as you might think, because trauma is both an event and the body and brain's response to overwhelming stress. Okay. Today, we're going to break down the DSM-5-TR trauma and stress related disorder category, the difference between trauma exposure and traumatic response, PTSD, acute stress disorder, adjustment disorder, and reactive attachment disorder. We also want to look at brain-based neurobiological aspects of trauma, cultural and social justice considerations, and clinical assessment and treatment implication. Okay. So let us start. What is trauma? The clinical definition is trauma refers to exposure to actual threatened death, serious injury, or sexual violence. But we also know that the impact of trauma is subjective. Two people may experience the same event and have very different outcomes based on biology, resiliency, social support, history of stress, and identity-based vulnerabilities. Trauma can be several things. Some of the key indicators are this: single incident, like an assault, accident, natural disaster. It can be chronic, such as ongoing domestic violence or living in a violent community. Very complex, repeated interpersonal trauma, often beginning in childhood. Historical and generational, including racial trauma, oppression, enslavement, and culture and colonization. Already you can see trauma is bigger than just one single event. It's biological, social, cultural, and psychological. Neurobiology of trauma, it is that trauma changes the brain. When the amygdala senses threat, it activates the fight, flight, or freeze response. The prefrontal cortex, the part responsible for reasoning, goes offline. And the hippocampus, which stores and organizes memory, becomes dysregulated. So this is why trauma survivors may feel constantly on guard, have trouble concentrating, experience emotional numbness, react to triggers that others perceive as minor, have fragmented or intrusive memories. The brain adapts for survival, but those adaptations can become maladaptive when the trauma is over. Okay. When it comes to post-traumatic stress disorder, PTSD requires exposure to trauma and includes four major symptom clusters: intrusive symptoms, flashbacks, nightmares, intrusive memories, distress to reminders. Avoidance, avoiding thoughts, places, conversation, people connected to the trauma. Negative alterations in cognitive and mood. You have shame, guilt, distorted beliefs about self or world, emotional detachment. And finally, alterations in arousal and reactive, irritability, hypervigilance, exaggerated startle, sleep disturbance. These symptoms must last more than 1 month and cause clinical significance and the distress or an impairment of the individual. When it comes to acute stress disorder, similar to PTSD, but the symptoms last at least 3 days to 1 month following the trauma. It can be a predator, a predictor for PTSD, but not always. Some individuals recover naturally once the nervous symptoms stabilizes. When it comes to adjustment disorders occur when someone develops emotional or behavioral symptoms in response to an unidentified stressor, such as divorce, job loss, academic failure, or breakup. The key features to this is symptoms appear within 3 months of the stressor, marked distress that is out of proportion to the severity of the stressor, and impairment in function. Adjustment disorders often get minimized but they can significantly disrupt life and are commonly in counseling settings. Reactive attachment disorder or disabilitated social engagement disorder. These disorders develop in childhood as a result of severe neglect or emotional deprivation, typically in early attachment years. Reactive attachment disorder, RAD, a child is withdrawn, avoids comfort, limited positive affect, overly familiar behavior with strangers, and lack normal boundaries. Okay, so when it comes to disinhibited social engagement disorder, the child is super friendly with strangers, and they have a hard time recognizing boundaries. These disorders require careful assessment and clinical sensitivity. Complex trauma. Complex trauma isn't a formal DSM diagnosis, but clinicians and researchers recognize it when trauma is chronic, developmental, interpersonal, and often occurring in childhood. It is linked to disassociation, personality changes, chronic emotional dysregulation, and difficult forming safe relationships. Some of the cultural and social justice considerations are we can't talk about trauma without acknowledging systems. Within the systems of oppression, we have racial trauma, community violence, immigration trauma, police violence, generational trauma from slavery, colonization, or displacement. Clients from marginalized communities and groups may experience trauma that is ignored, minimized, or mislabeled by different institutions. Cultural competent clinician must understand context, not just symptoms. So when you have a need, you need to ask yourself, how might trauma look different across culture? Who gets access to treatment? And what causes trauma? Whose trauma does society validate? And whose is dismissed? Some of the assessments that are used in measuring trauma are the clinician administrator PTSD scale, or CAPS-5, the PCL-5, post-traumatic stress disorder checklist, ACEs, the adverse childhood experiences, not diagnostic, but predictive, and trauma-focused clinician interview. Collateral information when appropriate. Survivors sometimes underreport safety, trust, and rapport matters. So that's something you got to be very aware of when you're looking at these assessments. Treatment approaches. Some of the evidence-based interventions include trauma-focused CBT, EMDR, prolonged exposure therapy, cognitive processing therapy, somatic and body-based interventions, mindfulness and grounding strategies, and culturally relevant and community-based healing practices. Trauma work requires pacing. Too fast can re-traumatize individuals. Too slow can feel unproductive. Remember, the therapeutic alliance is the strongest predictor of success. Right? But before I close, one of the things I want to talk about is epigenetics and trauma. And we talked a little bit about neurobiology, but let's talk briefly about epigenetics. Epigenetics is the study of how environment experiences, especially trauma and chronic stress, can change the way genes are expressed without changing the DNA itself. In other words, trauma doesn't rewrite someone's genetic code, but it can turn something, and it can turn some genes on or off. This influences brain development, emotional regulation, immunity, and stress responses. An example of this is when a child grows up in a home filled with fear, unpredictability, or violence, their body learns to stay in survival mode. Cortisol stays elevated. The amygdala becomes more reactive, and stress response pathways become primed for danger. Over time, these adaptations can become embedded in the nervous system. But here's where epigenetics becomes even more powerful. In intergenerational transmission, research shows that trauma-related changes in gene expressions can be passed down to future generations. This is often called intergenerational trauma or transgenerational trauma. Some example of this is the descendants of the Holocaust survivors show higher rates of stress sensitivity. Children born to parents with unresolved trauma may have altered cortisol regulation. Communities impacted by enslavement, colonization, genocide, and systemic oppression carry biological imprints of trauma. So when we see higher rates of PTSD, depression, anxiety, hypertension, and medical illness in certain communities, it is not simply individual psychology. It is more biology shaped by history. The good news is epigenetics changes are not permanent. Healing relationships, safety, nurturing environments, psychotherapy, cultural reconnection, nutrition, and community support can actually change gene expression again toward resiliency. So trauma can be inherited, but so can healing. So when we think about trauma clinically, we must understand its biological impact, its psychological impact, and its generational impact. Trauma is carried in the nervous system, in families, and in cultures. This is why trauma-informed work requires compassion, patience, and a deep respect for the lived experience. So if you have any questions, do not hesitate to reach out to me. Thank you.